guys, it's me, Adam Deshawn. I'm here with another video. I know you guys have missed me. It's been like 6 months. Not 6 months, like 3 months. I'm sorry, I don't know what I'm talking about. It's been like 3 months since I've made a video. And the last video was kind of a sad video. The coronavirus had come out and completely killed all of our lives. And, I was just making this really depressed video about how the coronavirus has impacted nursing and is still ravaging nursing apart. So nothing has changed. But this video is going to be discussing how to document as a nurse. So a lot of you guys are either starting nursing school or graduated back in May or even graduated or are going to graduate here in August. So this video is probably just in time for you guys on how to document as a registered nurse or LPN or whoever, just how to document. So first order of business is going to be discussing when documenting medication. You always want to use your 6 rights, or is it 7 rights? I don't know. It's 6 or 7 rights. I know they seem to add a new right every time I went to nursing school. Back when I was in LPN, there was like 5. When I went back to RN school, there was 6, and then when I went back to BSN, it was 7. So I don't know how many rights, but make sure you use those when giving your medication. But I really want to talk about documenting different types of situations that you will come in contact with in nursing. So the first one I had, y'all know I have to write my list out. I have no. So let's talk about a patient's refusal. So let's say that a patient is refusing a type of procedure, medication, a different or a type of treatment. Depending on what it is, you always want to document their refusal. You always want to document their refusal. That is one of the top things you always want to document. For instance, if they do not want to take a medication, not only do you want to document on the MAR that they didn't take their medication, but you kind of maybe want to make a little nurse's note. A lot of time, the electronic charting will let you go into the actual medication administration record right there at the medication card, or right there where you're getting ready to administer the medication. Will go ahead and let you make a nurse's note right then. Usually what my nurse's note looks like whenever a patient refuses a type of treatment, medication, procedure, this is sort of what my nurse's note sounds like. Patient refused, let's say I'm giving this patient lisinopril. Patient refused lisinopril despite therapeutic education of how lisinopril will lower blood pressure or something like that, blah, blah, blah. Patient verbalizes understanding or not understanding, will continue to monitor. Of course, we'll continue to monitor that little sprinkle on top. That just says, that's just letting whoever the reader know that you are continuously monitoring the situation, whatever it may be. First, you want to document that you educated the patient that this procedure or medication was therapeutic to achieve whatever the end result is. You always want to say that you explained it to the patient. You never want it to seem like, oh, you refuse? All right, cool, whatever, whatever, live your best life. No, you always want to document the refusal, that you educated the patient and what their response was to the education. Did they understand it? Did they have more questions? And also you want to document that you alerted the physician. Now, this does not have to be in real time. If you want to finish your med pass, and you want to let the physician know, hey, Dr. So-and-so, Miss So-and-so refused her lisinopril this morning, blah, 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 blah. I always want to document that you let him know. Documenting a fall or incident or an occurrence is all different types of names depending on where you work. First of all, you never want to put a occurrence sheet or state that there has been an occurrence in the medical record. So this is for lawsuit purposes. First of all, disclaimer, all documentation is so you don't get sued, okay? So you or the nursing facility that you work for does not get sued. That is the point of documentation. And also, you know, you want to monitor what's been going on with the patient. That is why you document as well. But the reason why we have such a emphasis on documentation is so we don't get sued, basically. Sorry. So let's say a patient falls. So back when I was working in a nursing home, I was, you guys, some of you guys know I was like the evening nurse supervisor. And what I was responsible for was the occurrence reporting. That was one of my tasks. The occurrence reporting. Making sure if there was an occurrence, if there was a fall, a patient was injured in any kind of way, there was a skin tear, there was anything like that, I had to review that documentation. Let's take a fall for instance. Let's say you witness a fall or you don't witness a fall. Let's say you walk into a patient's room and you see the patient sitting on the floor. First thing you want to do is you want to make sure the patient's okay. I mean, nothing else matters. You want to assess that patient for injury right there on the floor. You don't move them until you assess them on that floor. Do range of motion. Look at their skin. Do a neuro check. See if they're, neurologically at their baseline. And you want to document that. Get a set of vital signs. And then once you have cleared that this patient is able and is safe to move this patient to a more comfortable position, you do so. Never leave the patient when you find a patient on the floor. You leave them and you call out for help. When I usually document a fall occurrence, I'm very detailed with it. That's just been my training over the years. One thing I was always trained is that when you walk into a room, you see a patient on the floor, first thing you do is ensure that the patient is okay. Then you want to do an investigation. What happened? How did this patient fall? Can you find out how they fell? And what can we do to prevent it the next time? That's always what you want to document. Let's take this nurse's note, for example. Enter patient's room. Observe patient sitting on the floor in front of their wheelchair. Patient assessed for injury, range of motion done without pain, vital signs stable, neurological checks are intact. Move patient to bed. Upon investigation, notice that the patient's pillow was sitting in the floor behind them in front of the wheelchair, indicating patient possibly may have slid out of their wheelchair. This nurse applied non-skid cushion in wheelchair to prevent further occurrences. Something like that. So what you did was you saw what happened and you fixed it. Okay, you always want to talk about what you did to prevent the next fall. Documenting a patient's changing condition. So whenever there is a change in a patient's baseline, you always want to make a nurse's note and you always want to document the change. What is going on? You always want to use very objective assessments. What do you see? What do you hear? What did the patient say? What did the family member say? What did the staff member say? You always want factual data. Or if you're not, because you're not a physician, so you can't make a diagnosis. You can only talk about what you see as a fact. Enter patient's room, observe patient with left-sided facial droop, flaccid left side, grip strengths, patient slurred speech, drooling out of the left side of their mouth. Now we all know that this patient is having a stroke. But you can't say that because you have not seen a CT scan, you have not did an MRI. You can only talk about what you saw and let the physician know what you're seeing. Now, when you're on the phone with the physician, you can say, hey, I think she's having a stroke, or I think she's having a CVA, but you're not a physician. This has not been proven yet, so you can't go yelling out diagnoses that you don't know about. Wounds and skin. Now, wounds and skin is a whole different ballgame when it comes to documentation, especially if you're working in a nursing home setting. If you are not very well versed on pressure sores, that is something that can get kind of tricky. Now, if you're comfortable with staging a pressure sore and you pretty much know what it is, it's okay to call it a stage 1, a stage 2, a stage 3, a stage 4, unstageable, or a suspected deep tissue injury. That's okay to call it that if you feel like you know what that is. Now, if you do not, You always want to document what you see. For instance, let's say you're doing the shift and you roll a patient over and you notice some redness on their bottom. And you know this is something that needs to be talked about or documented on, but you really don't know. You're not confident enough to call it a pressure sore. So what would you do? Chart what you see. Redness noted to patient's coccyx and bilateral buttocks. Area is not blanchable, meaning that it does not turn white when you press your finger in it. Patient states pain with palpation. Always document what you see. Let's say you walk into and you see a patient's heel, and you're not very well versed on staging pressure sores. What do you see? Patient's right heel noted to be um, re, open area to left heel with a scan amount of serosanguinous drainage. Appears that epidermis is sloughed off or peeled off. Now, we all know that is some of us know that that's a stage 2, but if you're not comfortable with calling it that, do not stage it, because you may be wrong. And usually once you stage something initially, you can't go back. So just document what you see. Document what you see. This does not have to be factual. It has to be factual, but it doesn't have to be all this fancy stuff. Document what you see, and call the doctor. After everything you document, you always want to document MD aware. You always want to document MD aware, because you're letting the doctor know. It doesn't always have to be in real time, but the physician has to know every change with that patient. And that gives, that also gets it off you a little bit. If the physician doesn't want to do anything, physician aware, MD aware, doctor so and so is aware. You always want to document that you've made the doctor aware. If you're documenting something, the physician needs to be aware. That's all, you guys. I appreciate all of you guys hanging with me throughout these few months. I know it's been hard. I've been having a difficult time with the coronavirus, and I've also been having a difficult time with the racial inequality that's been going on in the world. So I said on an Instagram post that there is nobody more stressed out than an African-American healthcare worker. And I mean what I said, and I said what I mean. Have a good evening.